morning, everyone. Thank you very much, Derek, and thank you very much for giving us the opportunity. I suppose I hope you can realise that for something that's been our passion for the last 4 or 5 years, both myself, my co-investigators, and Anya Murphy, who should be here, our project manager, it's a fantastic opportunity to become and able to tell you all about our work. Particularly as this is an umbrella organisation for patient support groups, to be able to come and speak today to really what's our target audience. We're here to try and support patients in prostate cancer care. Again, it's a fantastic opportunity, and it's nice to hear that my talks follows on so well from what Rishi had to say as well. So IPCOR stands for Irish Prostate Cancer Outcomes Research, and as you can see there, it's funded by the Irish Cancer Society and Movember. It's funded initially for 5 years, and we're 4 years into the project. And together with my co-investigators, who I've listed there, we have been working tirelessly in the area of prostate cancer outcomes. Essentially, my co-investigators include the specialties that are essentially look after patients with prostate cancer. As a urologist, I'm the PI, and Frank Sullivan is a radiation oncologist, and Professor Ray McDermott is a medical oncologist. Frank actually sat on the panel that devised the ICHOM prostate cancer, the first ever ICHOM guidelines, I believe, on local prostate cancer. So it's a nice link between ICHOM and prostate cancer outcomes here in Ireland. Together with Linda and Conan, Conan Donnelly is the head of research at the National Cancer Registry, our main collaborators, and Linda is a clinical epidemiologist who gets heavily involved in cancer epidemiology. Our project manager is Anya Murphy, and she's been there since the very start. And we recently recruited our fellow, Dr. Cara Dooley. As you can see there from the bottom of the slide, it's really a conglomeration of a number of collaborations all across Irish healthcare, but particularly those charged with the care of cancer. We involve the National Cancer Registry as our main collaborators, and we fund the collection of a very extensive prostate cancer data set, much more extensive than they ever would have collected within the Cancer Registry before. We also are aligned with the National Cancer Programme as well, the NCCP. I was the lead for prostate cancer there for some years, and therefore the Cancer Registry, the Cancer Programme, is very much involved in IPCOR, and very much wants to see this as a pilot programme that we might be able to roll out to other cancer types across the country with IPCOR's success. We've also partnered with the Clinical Research Facility in Galway, who manage our patient-reported outcomes collection, and we're physically located in the Clinical Research Development offices there on Mount Street in Dublin. We're also, as I said, funded by the Irish Cancer Society and Movember. Obviously, being part of the Movember global group is crucial for IPCOR. It's really placed Ireland at the heart of cancer outcomes research across the world. Movember operates in a number of countries, and we are mimicking projects that are being carried out right across the globe, established essentially in the state of Victoria initially, but have now been rolled out across all of Australia. And much like what Rishi said, we are collecting the same information right across the globe so that we be able to compare our outcomes with those of obviously larger countries than ourselves. And we also collaboration with Cancer Trials Ireland. We are listed as a research project with Cancer Trials Ireland. So the data we're collecting in IPCOR is essentially two types. As I mentioned, we're collecting a very extensive clinical data set. So what we are doing is collecting up to nearly 400 variables now, right across a patient's cancer journey, starting off with their initial PSA, which is a prostate blood test, their initial PSA with their GP, right through to their diagnosis, how long they're waiting to be informed of their diagnosis, right through to their treatment, going on then into their outcomes, the complications from their various treatments, if they ever get disease recurrence, and what ultimately those treatments would be, right up to patients who ultimately might die of their disease. We'll be capturing longitudinally the entire patient's journey through annual chart reviews and filling in our data set. Our second and probably most important aspects to IPCOR is capturing patient-reported outcomes. I don't think I need to elaborate very much, but to the importance of PROMs that Rishi has already mentioned. But outcomes research is the foundation for the quality of healthcare delivery. All IPCOR men will be asked to complete a range of questionnaires. The questionnaires we've chosen, and we've agreed these right across the globe, is mainly the EPIC 26 questionnaire. All the projects that Movember funds right across Australia, Germany, America, England, and several other countries, we've all agreed to capture our data using the same questionnaire so that we can compare our patient-reported outcomes. EPIC 26, as Rishi mentioned, is crucial in prostate cancer follow-up because it captures the patient's urinary, sexual, and bowel and quality of life outcomes as well. So if we can compare those right across the globe, you can imagine the importance of that data. We're also going to include 2 clinical quality of life questionnaires as well. And all our patients will be able to not only complete these questionnaires by paper through the mail, but also through our website and also apps that we've developed as well through iPad and iPhone as well. These are just the ICHOM standard data sets that have become now really the gold standard for data collection. And right since the start, as I said, with Professor Frank Sullivan involved in IPPOSI, we instituted this ICHOM data set so that we are capturing all the data variables that ICHOM have outlined, that we'll be able to compare our outcomes, benchmark really the quality of care that we deliver in Ireland with our neighbours in England, but right across into Australia and America. There's a project right now going on through Movember called True North, global data set, and they are essentially the Cancer Registry in Ireland have signed an agreement with Monash University in Melbourne. We're going to be able to share the data from Irish prostate cancer patients with those right across the world, and this will all be collaborated in Monash in Melbourne, and they're going to send out reports. And the whole idea is that we'll be able to compare our outcomes with the best in the world, and we'll be able to share our, what we do properly and what they do properly and learn from each other, and hopefully we'll see an improvement in outcomes right across the world. So why are we collecting this data? Well, we'd like to analyse the data to improve outcomes in our Irish prostate cancer population. We want to produce reports and provide recommendations to hospitals and the National Cancer Control Programme and our healthcare providers, both public and private, as to how we can improve prostate cancer care. All the reports that we report, all the information will protect the hospitals and the individual doctors so that they will willingly give their information. Similar databases have been set up in Australia and the UK, as I said, and we'll be comparing our data on a truly global level. What are the ultimate goals of the IPPOSI study? Well, we aim to create national standards for prostate cancer care across Ireland. It's essentially a quality improvement initiative. We'll be collecting data and producing reports that will influence and improve prostate cancer care. We'll ensure the decisions about prostate cancer care are both transparent and based on high quality data. Currently, you'd have to say, questionably, that resources could be sent into lots of different areas right across the Irish healthcare spectrum, but are they getting value for money? Probably not. And therefore, we'll be able to look at what are the outcomes, not only the clinical outcomes, are we treating our prostate cancer patients to a high quality, but what are the issues that matter to patients? And if there's no little point in curing patients if patients are having very poor outcomes, we want to get a happy medium where patients are able to be cured and treated, but also get high quality outcomes. This vast data set that we're going to collect will allow us to perform very high quality research right across the entire population of Ireland. And we'll be able to compare our quality standards right across the world and make sure that we achieve the highest quality. So how can IPPOSI benefit Irish patients? Well, IPPOSI is about ensuring that patients have equal access to high quality health outcomes. So we're looking at making sure that if you're living in West Mayo or North Donegal, that you'll be able to access the same services and achieve the best quality of care as to someone who's living in an urban centre in Cork, Galway or Dublin. And we are looking at all those outcomes. IPPOSI will change, I think, most importantly, the focus in Irish healthcare. Just as Rishi has said, we'll be looking at health outcomes rather than clinical outcomes. We're looking at patient-reported outcomes. The outcomes are going to be the things that are going to be driving the changes. Just like we said, funding will be provided based on our outcomes. So this is the first sort of, I suppose, encroachment in Ireland into this area. Patients have really been involved with IPPOSI right from the start. On our steering group, we liaised with the Men Against Cancer, which is a peer-to-peer cancer support group supported by the Irish Cancer Society. And Jim Scott has sat on our steering group for many years and recently handed over the role to Tom Hope. And we're very appreciative of all their input on behalf of patients into our steering group. But we're going to expand our services as we move into a kind of a new era now at IPPOSI in terms of reporting and getting our results out to patients. We're looking to form a patient panel
a group of patients, particularly from patient organisations, that will be able to inform what we're doing correctly and how we can look at our results in a new, different light and help us to improve our outcomes research. If there are any patients or patient groups that would like to get involved in this, please do send me an email if you wish. But we'll be writing to patient organisations and support groups looking for volunteers to get involved in our patient panel. This is our website, and you're obviously welcome to go to it at any time for further information. What we would like this website to become is essentially a patient portal. We want to see this to become that everybody diagnosed, or anybody diagnosed with prostate cancer in Ireland would be able to go to this website for the necessary information and support patients. You can see there that log into your questionnaire, patients can click on that, and we brought into a separate area where they're able to put in their patient-reported outcomes using their IPCOR ID. So just in practice, how does it all work? Well, what we've done we've recruited registration officers through the Cancer Registry. These are individuals, we have 4 of them, 2 in Dublin, 1 in Cork and 1 in Galway. And these individuals attend right at the sort of the coalface of clinical management. They attend our multidisciplinary team meetings that occur in most hospitals on a weekly basis. They sit in the MDT, and that's where patients are diagnosed with prostate cancer. They're able to capture the patient's ID and their details right as they are diagnosed in our hospitals, so that there's no delay in getting these patients registered into IPCOR as soon as possible. When the patient comes back then for their diagnosis in the clinic, they're given information and a leaflet that IPCOR will be in touch with them at some point in time. And then we register the patient in our Cancer Registry database in the Cancer Registry, in National Cancer Registry. And once we are clear that the patient has been informed of their diagnosis, the Cancer Registry will be in touch with the patient, sending them out information about IPCOR. In order to keep on in touch with the patient, we do need their consent, and the patients do have to fill in a consent form in order to complete their PROMs and annually thereafter. The medical charts are then queried on a regular basis every 6 to 12 months, and the patient's data is then entered into our database depending on what treatments they've had, what complications they've had, and whether they've had any disease recurrence. So when it comes to the output from IPCOR, we'll be essentially doing this in 2 different ways. One of which will be annual reports, and there'll be 2 different types of annual reports. And the other way will be physician and hospital reporting. So our annual reports will consist of a sort of a simple version and a more complicated version. So we'll have a general report that will be made available to patient groups, which will have our basic information in it and outcomes on the year. There'll be a more detailed clinical report. Both of these reports will be available online, but this will be a report with much thicker and much more detailed on clinical outcomes as well as patient-reported outcomes. We're also, I think, most crucially going to report not only to the individual hospitals that have contributed to IPCOR, but also the individual doctors and surgeons. So every hospital will receive their own report as to what patients they have treated and what the outcomes of those patients have been on an annual basis. As a clinician who works in hospitals, you'd be amazed at, unfortunately, how ignorant our hospitals are on what patients are actually treated within their hospitals and what their outcomes are. Hospitals don't really know how many patients they've treated in various conditions. They don't know what types of surgeries they've had. They don't even know what the outcomes of those patients are. So we're hoping to actually supply hospitals back their own information about their patients and how their patients are doing. All the hospitals will be made aware of where their patients sit on a national picture but they won't be aware of who the other hospitals are. But obviously, if you're the leading hospital in the country in terms of prostate cancer care, that'd be a great thing. We would hope that hospitals would aspire to those sort of outcomes. So hopefully people will try to aspire to achieve better outcomes, and you'll see improvements on a year-to-year basis. We'd love to see some sort of an acknowledgement of hospitals through IPCOR if they achieve high outcomes, or individual doctors who might be able to achieve high outcomes for their patients. Those doctors might be acknowledged and obviously recommended. Obviously, as I said, doctors will receive their own individual reports as well then on the patients that they will have treated throughout the year, and the complications or the outcomes from their patients. And again, they'll be able to see how their patients are doing compared to the national average or means and so on. This is just a brief sort of synopsis on some of the outcomes that we were reporting on. So just in terms of some of the clinical analysis and reporting, there's essentially three components that Movember feel and ICHOMP feel are very, very important in terms of reporting. These fall into three categories: safe and effective and patient-centered care, appropriate care, and timeliness, equity, and access to care. So important outcomes such as treatment failures in the first 3 to 4 years after treatments commenced at 12, 24, and 36 months, patients' physical and mental quality of life at 6, 12, and 24 months, urinary and sexual function after their treatments, and the volume of patients and treatments at each site, making sure that treatment centres are seeing a high volume and high through output, as we know that those sort of high volume centres achieve the best outcomes. Appropriate care, in other words, are the right patients receiving the right care? Are we appropriately treating patients? Are we not making sure that we're not over-treating patients with low-grade disease and not under-treating patients with more aggressive disease? I'll allude to it in a minute, but we're going to be, all the patients' information will categorize the patients into one of 10 categories. There's a system called CAPRA, which is the Prostate Cancer Risk Assessment Score developed in LA, and all patients are divided into one of 10 groups. Group 1 and 2 would be the mildest form of disease, whereas Group 9 and 10 would have the more aggressive forms of disease. So we'd be able to monitor whether patients with the milder forms of disease are being treated not excessively and appropriately, and therefore making sure that patients with the more aggressive disease receive more aggressive treatments. You'd expect patients who have mild forms of disease, who will receive the more or less invasive treatments, should have the best outcomes. So we'll expect patients with CAPRA 1 and 2 and 3 to do very well. So we'll be looking for outliers to make sure that patients are and centres are maintaining good high quality outcomes in that more favourable population. Also, I suppose from the patient's perspective, we'll be looking at timeliness, equity, access to care. What is the time from referral? How long are patients waiting to be seen in hospitals? How long are they waiting to be informed of their diagnosis and start care? The effect of their socioeconomic status, obviously public versus private care. In IPCOR, that's irrelevant. We are capturing prostate cancer care right across the entire country. Whether you're a public patient or a private patient, IPCOR is present in each hospital capturing that information. We're capturing information at 6 or 7 of the biggest private hospitals in the country, and we'll be comparing the outcomes of those patients with patients in the public system as well. We'll also be looking at geographical variation, as I said, making sure that no matter where you live in Ireland, you have equal access to your treatment options, timeliness of service, and making sure that the outcomes in patients who might be more geographically challenged are equally as good. That's just a snapshot of the end of our, when patients complete their questionnaires, they're offered to download our app onto their phone, and through that they're able to monitor their treatment, they're able to input any problems they have, they're actually able to put in their questionnaires as well when asked by email. So obviously very much putting it into the patient's pocket. In addition to this, our collaboration with Movember has allowed us to achieve hopefully a lot more. In 2019, Movember have asked us to become involved really as one of the core countries in the True North program. And True North is essentially a patient portal. It's a website all about patient-centered support. It's got decision analysis software built into it where patients can log in, and it'll help patients to decide on what their best treatment options are based on their urinary symptoms and the state of their disease. It also supports patients throughout the whole of their journey, providing them with information. In the UK, this is being used then to support survivorship programs and survivorship clinics that Movember are supporting the development of right across the UK. And obviously, we'd love to see something similar to develop in Ireland as well. Just to show you some of the spin-offs that can come from collaboration between healthcare providers, as Rishi has kind of hinted at in terms of measuring outcomes. This is the music group in Detroit, and they have shown that by using health outcomes, they've managed to produce cost efficiencies. They found that a lot of patients were being imaged unnecessarily with excessive amounts of CT scans and so on, and bone scans, who had milder forms of disease. And by measuring this, they were able to show reductions in scans over time, and therefore, from the healthcare provider's point of view, cost savings as well in terms of a health quality initiative. And so value partnerships have built up. where healthcare providers, patients and doctors can come together around healthcare outcomes to improve the quality and standards. So what I was just going to show you, as I mentioned, we do have some data coming through. Really just in the last number of weeks we received data on 4,800 patients, just the initial clinical diagnostic information on patients through 2016 and 17. And as I mentioned to you, this is data that has never really been seen or captured in Ireland before. So just very briefly, just to give you, just to whet the appetite on patient demographics, just 2016, we captured a few more patients in 2017 as our capture rate improved. But essentially, in IPCOR, we're essentially capturing over 200 patients per month, or 200 patients per month of men who are diagnosed with prostate cancer. The average age, that's the age distribution, this would essentially cover about 80 to 90% of all men in Ireland diagnosed with prostate cancer. So you can see the average age of diagnosis in Ireland is about 65. If you look back at the last data, the cancer registry we're quoting it was closer to 72 years of age. So we've actually shown that in the last 2 years, the mean diagnostic age of prostate cancer in Ireland is closer to 65. So essentially, 50% of men or under are all in the working population. This is very much a disease of fathers, of people in the working place, and therefore this has much larger connotations for people who have to take time off work. And the people who are self-employed. I know of stories where people's businesses have had to go under and so on because they weren't able to attend to their own businesses because of their prostate cancer treatment. So all those things have to be considered when we are thinking of the treatment options for our patients. Just a different way of displaying the data in terms of the age distribution. So looking at patient access to care, we just looked at the median times that patients have had to wait right across Ireland for the last 2 years. So time zero responds to when their PSA or their prostate blood test was checked by their GP, which would have sparked a referral. So on average, patients are waiting about 49 days until their diagnostic procedure is performed, which would be a prostate biopsy, and on average, 77 days until they're informed of their diagnosis. So you could argue quite a long time, 77 days waiting from the point of having a diagnostic test done to the point of being diagnosed and informed that you actually have a disease. We can obviously break this down for the public and private divide, and individual hospitals looking at the waiting times and seeing if there's any outliers or particular areas that need attention. This is just the workload of where patients are diagnosed in hospitals across the country. You can see about 50% of the work is performed in the Dublin hospitals, and about a quarter in the Cork and a quarter in the Galway hospitals. If you look at the status of hospitals, so overall about 2/3 of the work has been performed in the public hospital. So I think that really speaks a lot about the success of the NCCP initiative around the rapid access prostate clinics. I know from experience that a lot of patients who would have private health insurance are attracted to the rapid access prostate clinics in the public hospitals because they know they're going to see within a short space of time. And I think that's really a testimony to the success of the rapid access treatment system. And you can see about 1/3 of the patients would be diagnosed within the private sector. Just looking very briefly then at diagnostics, just raw data here, but the registration officers captured that about 3/4 of our patients were diagnosed in what we call the screening setting. So this would be a setting whereby patients don't have any symptoms but are having their prostate blood tests done in order to aid diagnosis. This flies in the face a little bit if you look at what a lot of the support groups would say in the public, to the public, that if you've got urinary symptoms, go see your doctor. But actually what we're doing is we're diagnosing 3/4 of patients have no symptoms at all. And that is very much where you want to be diagnosing patients. If you wait for symptoms in patients with prostate cancer, you've probably waited too late, because if they've got cancer, the disease has probably been diagnosed too late, and you have to diagnose it really at an asymptomatic level in order to achieve high levels of cure. This is important clinical information from the point of view of doctors. This is the Gleason scoring system, which some of you might be aware of, is the grading system we use in prostate cancer, looking at how aggressive the disease is. The graph on the left-hand side is the Gleason 3+3, which is the mildest form of disease, and then the severity of the disease increases as you go across to the right-hand side. So you can see about a third of our patients are diagnosed with Gleason 3+3 disease, and many of these would be amenable to surveillance scheduling rather than aggressive forms of treatment, whereas the other 2/3 of patients would probably need some form of treatment. So this information is really important in terms of the CAPRA and the categorization of patients, and making sure that patients who are amenable to surveillance and without can avoid aggressive treatments and the side effects that come with it. Just a quick look, although a little bit confusing, but we largely, you can see there that 4,200 patients are diagnosed with transrectal ultrasound guided biopsy, the commonest form available in Ireland. It's moving away on an international picture. More and more patients are having transperineal prostate biopsies. We just don't have resources in Ireland, and therefore I think this sort of slide calls to increasing the resources for transperineal prostate biopsy. It has a much lower infection rate and is a much higher pickup rate for prostate cancer. But we rely on transrectal ultrasound guided biopsies in Ireland, whereas our UK colleagues are very much moving towards transperineal as a safer and more complete biopsy technique, and I think we need to be heading in that direction as well. And this is just a quick picture of the type of imaging that's performed in prostate cancer. Just from a clinical perspective, what I can see there is that over 3,000 patients had MRI scans of the prostate. Again, resourcing MRI imaging is crucial these days in prostate cancer care, but it's nice to know that 3 out of 4 men are getting those types of imaging studies done. Just a quick look then, this is my last slide, but this is just about treatment for prostate cancer. So this is the surgical picture. And what you see very interestingly, compared to the 2/3 of patients who were all biopsied and seen in the public service, when it comes to actually having your operation and your surgery, we're seeing 2/3 of patients in the last 2 years have opted to have their treatment in the private service. For many of you may know, in prostate cancer, that really comes down to availability of robotic surgery. Patients are deciding with their feet whether they've got health insurance or whether they're willing to pay, or whether their hospital is willing to pay. Patients are moving with their feet and opting to have robotic service. So essentially what the public service really here is doing is they're having the private service do a lot of the work for them. But really a lot of these patients should be offered treatment within our public service if we had the right technology and make it available. So what's next for the IPCOR project? Well, you can see there, that's just some initial data, and we are publishing and disseminating our first data annual report in November, in keeping with the month of November. We're hoping to do a publicity campaign around that. We're actively collecting our patient-reported outcomes, and there's going to be a big mail out due the month of November, and we're going to do a publicity piece around that as well. We're also, as I mentioned, establishing our patient panel to advise us on the patient-reported outcomes and how we can improve that process and other aspects of IPCOR. We're also going to establish a research program early in the new year as well, as we start to interrogate our data a little bit more. We're also going to be providing data reports in the first quarter of 2019 to the individual hospitals and the individual doctors as well. And we have a lot of work to do around developing our website and making it more patient-friendly as well. We're also going to, we've always been, liaising with patient organizations, healthcare providers, also the industry and pharma, who have been very interested in obviously looking at this, because it'll mean that patients may be amenable to getting on cancer trials, making drugs available to patients who mightn't been otherwise had it available to them. And we're also involved with the Prostate Cancer Research Consortium in Ireland as well, where researchers and scientists will be able to interrogate our data and look at new roles for research in our Irish population. So you can find out more information. We're on Twitter and, as I said, our IPCOR website, and do feel anyone who wants to email me at david@ipcor.ie at any time. And just to finish up, I want to acknowledge all the people that have helped with IPCOR. Obviously, our project manager, Anya Murphy, has worked tirelessly with me over the last 4 years to make IPCOR a success. And I say we've recently appointed Cara Dooley as our research fellow as well. But there's a range of people there right through the Cancer Research Facility in Galway, the National Cancer Registry, our website developers, all our research officers, our members of our steering committee, data committee, our scientific advisory board, all the clinicians who have signed up to get their patients involved in IPCOR right across the country, all the Movember support and the support from the Irish Cancer Society, and of course all the Irish patients who have to live with their condition. Thank you very much.